Hello everyone, this is Dr. Praveen Kumar Nadarajan. The ECG has always been an investigation of fascination. Right from the time we joined the medical school, we are always wondered by the complexity of information an ECG gives. So in this session, I'll try to deal with the basics as well as the advances of the ECG. So let's go into the topic. So in this session, I'll try to deal with 6 basic topics. So the first one will be the basics. Second one is little bit advanced. The third one will be the most important ones, the acute coronary syndromes. The fourth one will be bradyarrhythmias. And the fifth one will be tachyarrhythmias. And the sixth one will be electrolytes. So let's go into the basics of the ECG. So what is an ECG or electrocardiogram? It is nothing but the recording of the electrical activity of heart by using electrodes which are placed on the surface of the body. So the heart is an organ which has autonomous electrical activity. The embryonic heart starts beating at 21st day after fertilization, which actually approximates to 5 weeks after the LMP. So 5 weeks after the LMP, the electrical activity of the heart can be recorded. So the electrical activity will travel through the surface of the body and it will be picked up by the electrodes which are placed on the skin, and that will be seen as the deflections which we see on the conventional ECG paper. Let us have a look at the history of ECG. Actually, in 1887, this gentleman named Augustus Waller. So he was the first one who recorded the ECG using Lippmann's capillary electrometer. So that was pretty crude, and he was able to identify only 2 positive deflections like this, both representing the ventricular activity, and he named them as V1 and V2. So he was the first one who recorded the ECG using Lippmann's capillary electrometer. Then comes this gentleman whom we are well aware of, Wilhelm Einthoven. In 1895, this guy improvised the Lippmann's capillary and electrometer, and he was able to record 4 waves which appeared like this. So he named them as A, B, C, and D. So he recorded 4 different waves and he named them as A, B, C, and D. And to correct for the Lippmann capillary electrometer's inaccuracies, he devised certain formulae incorporated into it, and he was able to identify a more refined tracing which appeared like this. He wanted to name these curves as A, B, C, D, and E, but he was actually inspired by a French philosopher and mathematician, Descartes. And he named them as P, Q, R, S, and T, because this particular gentleman, Descartes, he actually used the letters P, Q, R, S, T in his equations involving any curve, any unknown curve. So he was inspired by that particular scientist and named the new tracing as P, Q, R, S, and T, which we use till now conventionally. And for all these contributions he made, he was awarded the Nobel Prize in Physiology in 1924. So coming to the anatomy of the electrical system of the heart, it can basically be divided into two. The first one is sinoatrial node and the conduction system, and the next one is intraventricular conduction system. So the SA node and conduction system contains three parts. The first one is SA node proper, or the sinoatrial node, and the next one are the internodal tracts. And the third one are the AV node or the atrioventricular node. So actually this internodal tracts connect the sinoatrial node and the AV node. This is pretty inconspicuous and its function is not known yet. I'll explain about it later. And coming to the intraventricular conduction system, it actually consists of bundle of his. Bundle of his is actually a continuation of the AV node, and shortly after that the bundle of his divides into two branches. The first one is the right bundle branch, and the second one the left bundle branch. The right bundle branch is very thin and long, which actually ends in the Purkinje fibers. Purkinje fibers, whereas the left bundle branch actually divides into three more divisions. So the first one is left anterior fascicle, the second one left posterior fascicle, and the third one is pretty inconspicuous again, it is the mid-septal fascicle. The left anterior fascicle actually supplies the anterior and superior part of the left ventricle. Posterior fascicle supplies the posterior and inferior part of the left ventricle, and the mid-septal fascicle is supposed to supply the ventricular septum. These supply the ventricles only after getting converted into the Purkinje fibers again. So these constitute the electrical system of the heart, and I'll just give a pictorial representation of that. So this is how it actually looks. So this particular part is actually the SA node, and these are actually the internodal tracts. Internodal tracts. This is the AV node, and this is the bundle of his. This is the right bundle branch. This is the left bundle branch. This is actually the left anterior fascicle. This is the left posterior fascicle. This is the small mid-septal fascicle, and these small branches are the Purkinje fibers. So these are the electrical system of the heart. I'll explain every one of them in detail. So first one is the SA node or the sinoatrial node. So we actually know the particular term where the sinoatrial node is called the pacemaker of the heart. So why is it called the pacemaker? Actually, it is because of the automaticity it possesses. So the cells of the sinoatrial node produces spontaneous electrical impulses, and that actually gets conducted to the rest of the heart, and that is why it is called the pacemaker of the heart, because usually the rate of the beating of heart is normally decided by the rate at which the sinoatrial node fires. So what is the location? So if we consider this as the right atrium and this as the left atrium, this as the ventricle, the SA node is actually present in the right atrium, upper part of the right atrium, just near the entry of the superior vena cava. So it is present in the upper and right end of the right atrium. How is it supplied? That is of very much importance, because in around 60% of the times, the SA node is supplied by the right coronary artery. In the remainder, it is actually supplied by the branches of the left coronary artery. And coming to the third important point, the cells of automaticity, the cells which fire spontaneously, are actually evenly distributed throughout the entire substance of the sinoatrial node. So these are the facts which you should always remember about the sinoatrial node, or the pacemaker of the heart. Coming to the second one, these are the internodal tracts. So if we consider this as the sinoatrial node and this as the AV node, the internodal tracts actually connect the SA node and the AV node. So this is the anterior internodal tract, this is the posterior internodal tract, this is the middle internodal tract. These are all actually present in the right atrium itself. Actually, one more important thing which we should understand is the anterior internodal tract actually has a specific branch which goes and supplies the left atrium, and that is called the Bachmann's bundle. So it is supposed to supply the left atrium so that the right atrium and the left atrium contract simultaneously. Actually, we all know the impulse from SA node to AV node is usually conducted through the musculature of the atrium. So most of the researchers are wondering what can be the use of these internodal tracts. Obviously, these internodal tracts are just specialized myocytes. They are just the myocytes, which is the normal myocardial cells. They have some specialization and form a band-like structure. They still don't know what can be the use of these internodal tracts, except that you have to understand one clinical point where what sino-ventricular rhythm means. So we all know the normal rhythm of heart is the sinus rhythm, but what does sino-ventricular rhythm means? So I'll explain. In sino-ventricular rhythm, the impulse actually originates from the sinus node only, but there will be no P waves present. The P waves won't be present in the ECG, even though the impulse originates from the sinus node. So then how does it go to the AV node and then contract the ventricle? That is how they believe that these internodal tracts can carry the impulses without activating the atrium, so that these impulses can reach the sinus node to the AV node. And when does this particular thing occurs? Keep in mind, this is an important MCQ. So this occurs during hyperkalemia. In hyperkalemia, we all know that the P wave's amplitude slowly reduces from the normalcy. It slowly reduces and becomes absent. So this absence is due to atrial paralysis, and during this time, even though the impulse originates from the sinus node, it goes to the AV node via the internodal tracts. So this is one point which you have to understand about the internodal tracts. Now coming to the most important part, the AV node. So the AV node, again, like the sinus node being called as the pacemaker of the heart, the AV node is called as the gatekeeper of the heart. So why is it called the gatekeeper of the heart? That means it helps in delaying the impulse propagation from the atrium to the ventricle. So when the atrium is here and the ventricle is here, one thing which we should understand is that the atrium is totally electrically disconnected from the ventricle by a fibrous band of tissue, the fibrous annulus, except for one particular region, which obviously is the AV node. So any impulse which originates from the atrium can go to the ventricles only through the AV node, and the AV node has an intrinsic property of delaying the conduction. So only when the atrium gets completely depolarized and completely contracted, and only after the blood from the atrium enters into the ventricle, the impulse will reach the ventricle, so that the ventricle will contract only after the ventricle is completely filled. So it means only after the atrial contraction there will be a delay in impulse conduction to the ventricle, so that there will be a sequential contraction of the atrium followed by the ventricles. That is the most important use of the AV node. So how does AV node do this? This is actually the three anatomical parts of the AV node. I'll explain how it is. So consider the atrium which is present above, and consider the ventricle which is present below. Okay, so AV node can be divided into three structures. The first one is called the AN region. The second one is the nodal region or the N region, and the third one is the NH region. So you can easily understand that. So what is present above? It is the atrium. So the part which connects the atrium to the node proper is called the AN part, and this is the node proper, which has various important properties which I'll explain, and the lower part which connects the node to the bundle of His. So that is why it is called the nodo-His region or the NH region. Coming to the properties of the nodal region. You have to clearly understand that the delay in the impulse conduction occurs only in the nodal region. So that is the first important work which is done by the N region, and the second important thing is acetylcholine secreting nerve endings are actually present in the N region. So acetylcholine, as we all know, is secreted by the parasympathetic system mostly. So the parasympathetic system actually slows down the heart rate. So that is the mechanism how AV node actually slows down the impulse during increased parasympathetic activity. During increased parasympathetic activity, the acetylcholine gets secreted in the nodal region, which actually delays the conduction further and results in a slower heart rate or the bradycardia. That is one important function. And the third important function is the nodal region proper has no automaticity. That is, if there is no impulse coming, actually one important point which you all have to remember is almost the entire part of the heart possesses cells which have automaticity. So even though the sinus node doesn't produce any impulse, there will be few other cells from different parts of the heart, like the AV node or the bundle of his or the his Purkinje system, or even the ventricular myocardium or the atrial myocardium. Anything can possess the automaticity, and that can become the dominant pacemaker of the heart. But this particular system, that is the nodal region, actually don't possess automaticity. So even though if it doesn't receive any impulse from above, there will be no de novo production of any impulse in the end region. But this AN region or the NH region has cells which produce impulses. So you have to understand one particular thing. There is a term called AV block. So AV block means there is delay in conduction of impulses from the atrium to the ventricle, which is more than normal. There are 3 degrees of AV block, which will be dealt later in the bradyarrhythmia chapter. But you have to remember, when there is complete AV block, that is when there is no transmission of impulses from the atrium to the ventricle, when there is a complete blockade here, anything which is present below the AV node can become the dominant pacemaker. If there is any impulse which has to originate from the AV node, then you have to understand it should be from the NH region. So this can become a pacemaker of the heart at the times of complete AV block. So these are the important things which you should remember about the AV node. And one more important stuff is the blood supply. Like the sinoatrial node, the AV node actually receives blood supply from the right coronary artery most of the times, which is around 90% of the times. Around 90% of the times it is from the right coronary artery, and the remainder of the time obviously from the left coronary artery. So let's go to the next region. So the next part is the his Purkinje system, which is actually thought to be the fastest conducting pathway of the heart. So let me draw the diagram of the heart again. This is the bundle of his. This is the AV node. So the bundle of his obviously divides into the right bundle branch and the left bundle branch. This is the ventricular septum. The right bundle branch is actually long and thin when compared to the left bundle branch, which is actually short and little bit thicker. And there are no branches except for the Purkinje fibers, whereas here there are 3 branches. And another important thing is both of these are not affected by the autonomic nervous system. So the sympathetic or parasympathetic influence actually don't affect the conduction to the his Purkinje system. That is one important thing. So even when there is a heightened parasympathetic activity, the bradycardia is mainly due to block at the AV nodal level, whereas the his Purkinje fibers will usually be unaffected. And another important anatomical aspect which we should remember is, once the bundle of his divides into right bundle branch and left bundle branch, they course through the endocardium. That is, it courses through the endocardial region, which is actually the innermost part of the myocardium. So when we look at the myocardium, this is the inside part, which is the ventricular cavity. This is the outside part. So the part which is outside is obviously called epicardium, and what is inside is the endocardium, and what is in the middle is called the myocardium. Okay, so this his Purkinje system actually courses through the endocardial region. So you can, it is very evident from this particular region itself. So this is the epicardium, this is actually the endocardium. Here also, this is the endocardium, this is the epicardium. The bundle of his and the his Purkinje system actually travels through the endocardium, so that the impulses first reach the endocardium of the ventricular musculature. From the endocardium, the impulses travel towards the epicardium. This is one important stuff which you should remember. I'll explain it later again. So these are the important facts which you should remember about the his Purkinje system. So let us go into the next part. Which actually is the electrophysiology, which is very important. Much understanding is needed about the electrophysiology to proceed further into the ECG. So coming to the electrophysiology, we should know about the three types of cells which are present in the heart. So the first one is the conducting type of cells. The second one are the muscular cells, and the third one are the pacemaking cells. So the diagrams which are present below are actually the action potentials which occur in each of the different cell types, and you can see that there are little bit variations which are present in the three types, whereas the muscular cell has a smaller one and the conducting type of cells has a bigger one, whereas the pacemaking cell has a totally different type of electrophysiology. So one particular term which you have to remember is the resting membrane potential, which is actually a resting state of a muscle cell or the conducting cell or the pacemaking cells. And the next one is the action potential, which occurs during the time of impulse propagation. Let me tell the basics of the resting membrane potential first. So have a look at a cell. So consider this as a cell, and this is the extracellular space. As you can see from the diagrams, the extracellular space has increased sodium which is present, whereas the intracellular space has increased potassium levels. So how does this occur? We all know about the basic Na plus K plus ATPase pump, which pumps actually 3 sodium outside and pumps in 2 potassium. So this is inside the cell, this is outside the cell. So as more positive charges is lost outside and only less number of positive charges come inside, the inside of the cell actually has a negative potential, so that the resting membrane potential of the normal cell is usually in a negative part. So coming back to this particular diagram, this baseline in each of the thing is actually the resting membrane potential. So the resting membrane potential of a muscle cell is around minus 90 millivolt, whereas the conducting cell, it is still negative, around minus 95 millivolt, whereas the pacemaking cell, it is more positive, that is, it ranges from minus 60 to minus 70 millivolt. So these are the values which you should always remember. So coming back, sodium, it is actually present in an increased quantity in the extracellular space, whereas potassium present more in the intracellular space. And coming to the third ion, which is the calcium. Calcium is also present in an increased amount outside the cell, as you can see here. There is another pump which you should remember, which is the sodium calcium exchanger. So consider this as the outside and consider this as the inside of a cell. This particular sodium calcium exchanger actually pushes out sodium as usual, whereas it pulls in the calcium. So when does this act is that if there is any condition where there is blockade of sodium potassium ATPase pump, then the sodium which is present inside the cell has to be pushed out by some other means. So this particular pump becomes active, so that sodium will be pushed outside, whereas calcium will be exchanged inside. So when is this particular thing important? We all know a very common drug, digoxin. So what digoxin does is that it sits in the place of potassium in the sodium potassium ATPase pump and blocks the sodium potassium ATPase pump. So during this particular period, there should be some other mechanism which should push the sodium outside. So this pump becomes active, as I said, and sodium will be pushed out, whereas calcium will be pushed in. So when more calcium enters inside the cell, we all know calcium is needed for the contraction of a muscle cell. So as more calcium comes inside, the force with which the muscle contracts more. So that is how digoxin exerts its inotropic effect. So that acts via the sodium potassium ATPase pump. And one more thing, I'll just give a clinical relevance to this. So this digoxin actually binds the sodium potassium ATPase pump where potassium actually sits. So the potassium binding part is where the digoxin acts. So when there is more potassium which is available outside, if there is more potassium outside, that will compete with digoxin, and so that the effect of digoxin will be less. Whereas when there is less potassium outside the cell, digoxin can easily bind the potassium binding part and the activity of digoxin will be more. So that is the reason why we call hypokalemia increases digoxin toxicity. So whenever there is hypokalemia while giving digoxin, we should always remember that the patient is more prone for digoxin toxicity. This is one point of clinical relevance. So let us go into the next part. So I told about the resting membrane potential. Now let us go into the action potential. This is a normal muscle cell and this is a normal muscular cell action potential. I'll explain how the action potential actually occurs. We all know the resting membrane potential of a muscle cell is minus 90 millivolt. So this minus 90 millivolt is actually maintained by the movement of positive ions inside and outside the cell, mostly potassium inside and outside the cell. And when there is action potential, when there is electrical current which comes from a neighboring cell to this particular cell, this causes depolarization of the cell. Depolarization means the cell becomes more and more positive, and that is due to movement of sodium inside the cell. That sodium is from the neighboring cells action potential I'll explain. So when sodium starts entering here, the potential, resting membrane potential, becomes less negative or it becomes more positive. So this is how it goes. So this is minus 90. You can see the 0 millivolt here. So the potential reaches to around minus 70. So minus 70 millivolt is very important value to remember, because that is what we call the threshold potential. So once when the membrane potential reaches to minus 70 millivolt, then there is one important activity which occurs. That is, at 70 millivolt, the fast sodium channels. Fast sodium channels open. So when the fast sodium channels open, we all know sodium is present more outside the cells. So when a channel opens, then sodium will move from outside the cell to inside the cell. So more and more sodium enters the cell, so that the potential of the cell becomes more and more positive, and it will be very steep. It will become positive very rapidly. And once the potential reaches 0 millivolt, the fast sodium channels actually close. But even though the fast sodium channels close, the rapid upstroke is so fast, so rapid, that it actually overshoots 0 and it becomes more positive to around plus 20 to plus 30 millivolts. So once the potential reaches plus 20 to plus 30 millivolts, there will be opening of the second channel, which is the transient K+, which is the transient potassium channel. So when the transient potassium channel opens, we now know potassium is present more inside the cell than the outside. So when the potassium channels open, the potassium actually goes outside the cell. So when potassium goes outside, positive charge is lost, so that the cell's potential becomes negative. That is, it falls from minus plus 20 or plus 30 back to 0. Okay, and there is another important stuff we should remember, which is the third thing. This fast sodium channel is the first thing, transient K+ channel is the second thing you should remember, and the third thing is something which happens at minus 40 millivolt. In minus 40 millivolt, there will be opening of the calcium channels. So as I said earlier, calcium is also present more in the outside of the cells. So when calcium channel opens, calcium again flows into the cell. So when a positive charged ion goes inside, again the potential actually becomes more positive. That actually happens during the upstroke itself, but this is more relevant in this particular part, where the potassium is lost outside. That is, positive charge is lost outside due to opening of the transient K+ channel, whereas the calcium keeps on entering the cell because it has already opened at minus 40 millivolt. So it keeps on entering the cell. So there is inflow of calcium, whereas outflow of potassium, so that the inflow and outflow gets matched at a particular time, and then the action potential remains in 0 millivolt. Okay, the potential of the cell remains at 0 millivolt. That is the plateau phase. After this plateau phase, the calcium channel again closes. So when calcium channel closes, there will be loss of inflow of calcium. When there is loss of inflow of calcium, the potassium keeps on going out, so that the cell's potential becomes negative again, and it falls slowly. It falls and falls and falls till it reaches the resting membrane potential, where the inflow and outflow of potassium of the potassium equalizes, and the membrane potential again stays in the resting membrane potential, which is around minus 90. millivolt. So let me summarize. So let me summarize. Initially the cell is at minus 90 millivolt and action potential comes, hits this cell, so that little bit of sodium enters. When sodium enters, the potential reaches from minus 90 to minus 70. During minus 70, fast sodium channels open and sodium goes inside the cell very rapidly, so that the action potential has a very steep upstroke. At 40 millivolts, there is also opening of calcium channels, so that calcium also flows inside the cell, and when it reaches 0 millivolt, there will be closing of sodium channels, which is the fast sodium channels, and when it overshoots and goes to minus 20 or minus 30, there will be opening of the K plus channels, so that there will be loss of potassium throughout, whereas during the plateau phase there will be inflow of calcium also due to this particular channel, and there will be equalization, so that there is a plateau phase, and then when the calcium channel closes, there will be continued loss of potassium, which results in reducing the membrane potential, and it goes to the resting membrane potential of minus 90 millivolt. So these are named as few stages, few phases. The phases are, the rapid upstroke is called phase 0. Okay, the rapid downstroke is phase 1. The plateau phase is phase 2, whereas the next downstroke is phase 3, and the resting membrane potential is called phase 4. So these are the 5 different phases of action potential of a normal muscle cell. Now we have to compare this action potential with that of a pacemaker cell. So as you can see, the action potential of a muscle cell is totally different from that of a pacemaking cell. You can see the membrane potential, there is no actually flat line which is present in a pacemaking cell. That is the most important property of a pacemaking cell, which results in its automaticity. I'll explain. So this is the phase 4 of a pacemaker cell. This is the phase 0, and this is actually the phase 3. Okay, the phases 1 and 2 merge together here, so that there is no phase 1 and 2 separately, whereas there is phase 3 here, and again there is phase 4 here. So why is this difference? I'll tell you. As I said in the previous thing, the fast sodium channels open at minus 70 millivolts and it closes at 0 millivolt. One peculiar feature about these fast sodium channels are that these channels can be activated again only when the membrane potential reaches minus 90 millivolt. So only at such a negative membrane potential the fast sodium channels can be opened. But here, as I said earlier, the resting membrane potential of a pacemaking cell is just minus 60 to minus 70. There is no minus 90, so that there is no chance of a activation of the fast sodium channels, because the fast sodium channels will be ready to open only when the potential becomes more negative. So here there is no role for the fast sodium channels. So how is the action potential generated then? That is why I am comparing these both. Okay, so at phase 4 we have to remember one important channel, one very important channel, which is the funny current. So what is a funny current? This funny current are nothing but a different type of sodium channels which actually depolarizes spontaneously and slowly. Unlike these fast channels, these slow sodium channels actually depolarize spontaneously, and they depolarize very slowly, so that the resting membrane potential so that the resting membrane potential increases from minus 60 millivolt and it slowly increases till it reaches minus 40 millivolt. Now if you remember, at minus 40 millivolts you can compare it with here where the calcium channel actually opens. So when the calcium channel opens at minus 40 millivolt, obviously calcium enters inside the cell, but these calcium channels are actually not as rapid as the fast sodium channels. These are comparatively slow channels. So there will be slow upstroke, which is actually the action potential of the pacemaking cell. So there will be slow rise, and since there is slow rise, there is no rapid upshooting also. There is no rapid upshooting and there is no overshooting to plus 20 to plus 30 millivolt like the muscle cell or the conducting cell. These pacemaking cells can go to a maximum of up to plus 10 millivolts, and then the potassium channel plays its role similar to the conducting cell. The potassium channel opens here, potassium goes out, whereas the calcium channel, again similar to here, the calcium channel also closes here. When the calcium channel closes here, obviously there will be loss of more potassium and the potential comes back to the normal resting membrane potential of minus 60 to minus 70 millivolt. So once it reaches minus 60 to minus 70 millivolt, again these funny current channels. So again these funny current sodium channels will open. So that sodium will again go inside slowly, and once it reaches minus 40 there will be calcium inflow, and once it reaches 0 or plus 10 there will be potassium channel which is opening and there is a loss of potassium, and there is also closing of the calcium channel after some time, so that there is no inflow of calcium. Okay, so that it falls back to the again resting membrane potential, and it again, due to funny current channel, it goes back to the threshold potential of minus 40. So the threshold here is actually minus 40. So these are the various important stuff which you people should remember about the action potential of a muscle cell and a pacemaking cell. The important channel is the funny current channel, which is actually a sodium channel, and I want to tell a particular clinical relevance to that. One clinical point with regards to the funny current channel. So there is a particular drug called ivabradine. So the ivabradine actually blocks these funny current channels. So what happens when the funny current channels are blocked? The upstroke of the normal resting membrane potential will become more slow. Okay, so when few channels are blocked, the resting membrane potential doesn't reach 40 as steep as this, as steep as normal, whereas it goes more slowly. And when it reaches minus 40, obviously there will be action potential which is generated, and it comes back to normal as usual, and again it doesn't rise fast, whereas it rises slowly. So what is the important thing which you can find from here is that in place of two action potential, there will be only one action potential which will be produced, so that the automaticity of the cell actually decreases. So when the automaticity of the cell decreases, then the rate at which the cell fires is also decreasing. So if the normal rate of firing of sinus node is around 60 to 100 per minute, whereas if you give ivabradine, it can fall. Okay, so this particular drug can be used when there is tachycardia due to a particular thing, or when there is tachycardia due to a particular thing, or it can also be given during heart failure. One important stuff is that it doesn't cause any depression of the myocardial cells. You have to remember, it only reduces the rate at which the sinus node fires. So there is only reduction of heart rate without reduction of myocardial contractility. So evaporation reduces the heart rate, but it doesn't compromise on the contractility of the heart. So this is one recent drug which has been used in many patients with heart failure now. Now going to the next part. So the next part I'll like to talk about the refractory periods. So refractory periods, we should understand that during the various phases of action potential, there can be a premature impulse which can hit this muscular cell at any point of time. So when a premature impulse comes and hits the muscle cell during this initial phase, that is during phase 0, 1 or 2, okay, the cell is actually maximally depolarized, so there is no chance of another action potential developing here. So this particular period is called absolute refractory period. So when there is absolute refractory period, there is no action potential which can be generated. So this is one important thing. The next one is from 0 to around maybe minus 25 millivolt. This particular period is called effective refractory period. During effective refractory period, there can be action potential which is produced, but there is no propagation of action potential. Okay, there is action potential which can be produced, which is small, but it can't be usually be propagated. So that is the effective refractory period. And the third one is from minus 25 to around minus 70 millivolt, which is actually the threshold potential. So that period is called relative refractory period. So during relative refractory period, AP can be produced, that is action potential can be produced by a very strong stimulus. Can be produced, and it can be propagated also. So it can be propagated also, but the propagation will be slow or ineffective. Can be slow or ineffective. And coming to the fourth important thing, which is from minus 70 to minus 90 millivolt. I'll write it here. The fourth part, which is the supernormal period. So why is it called supernormal period? You have to understand the concept here. So the potential during this period varies from minus 70 to minus 90 millivolt. So consider a cell which has minus 90 millivolt. So for this minus 90 millivolt to reach minus 70 millivolt, we have to give a certain amount of stimulus, which is a certain amount of positive charge. I'll tell in simple terms. Okay. So for example, the potential has to rise by 20 millivolts here. Okay, if the cell is in a resting membrane potential, the potential has to increase by 20 millivolts to reach minus 70, which is the threshold, so that there will be action potential which can be produced. But when the cell is actually in this particular phase, the potential of the cell is actually not minus 90 millivolt. It will be somewhere between minus 90 to minus 70, so that, for example, if it is traveling at minus 80. So if it is at the stage of minus 80 millivolt, 10 millivolt increase alone. So any impulse which produces just a 10 millivolt increase can again push the cell back to minus 70 millivolt, which is the threshold potential. and there will be a new action potential which will be produced. Okay, that is the importance of supernormal period, where AP is produced, action potential is produced by a even by a weaker stimuli. Whereas relative refractory period, the AP is produced by a strong stimulus, whereas in supernormal period, action potential can be produced by a weaker stimuli also, and obviously when AP is produced, it can be propagated also here. So just understand absolute refractory period, which is till the phase 2, where whatever be the strength of the stimulus, there won't be action potential produced. Whereas the next one is the effective refractory period, where a strong stimulus can produce action potential, but it won't be propagated. And the third one is the relative refractory period, where action potential can be produced by a strong stimulus and it can also be propagated, but in an ineffective manner or a slow manner. And the fourth one is the supernormal period, where action potential can be produced by a weaker stimulus itself and it will obviously be propagated. So these are the 4 types of refractory periods which you people should know.